The patient with a neurodevelopmental disorder. Neurodevelopmental disorders overview. Neurodevelopmental disorders are a diverse group of chronic and potentially severe conditions that typically manifest in the early developmental period, usually last throughout a person's life, lead to intellectual, social, and/or physical impairments, create problems with major life activities such as language, mobility, learning, self-help, and independent living. Many people with neurodevelopmental disabilities seek dental care in private and community settings where opportunities are available to contribute to the health and well-being of these individuals. Down syndrome and autism spectrum disorder are two major categories of patients with neurodevelopmental disabilities that dental professionals encounter in standard dental settings. Intellectual disorders. The definition: intellectual disabilities are characterized by limitations in intellectual functioning, limitations in adaptive functioning as expressed through conceptual, social, and practical skills, origination and onset of symptoms during the developmental period, usually before the age of 18 years. Functional disability related to ID represents a more or less important symptom in well over 200 different conditions. Models of human functioning in disability. Several models of human functioning or disability have been proposed to better understand the interactions of disability with individuals and environmental characteristics. Based on these, a model has been proposed to assess and support those with ID, which includes the following components: diagnosis, intelligence testing, problem solving, abstract thinking, judgment, academic learning abilities, ability to plan ahead, and assessment of adaptive functioning. In individuals with ID, about 1/3 have comorbid psychiatric disorders and 10 to 20% have behavioral problems. Assessment of functioning. Establish a baseline information for behavioral, social, functional problems. Assessment of support needs. Planning and developing individual supports. Assessment of personal outcomes, including quality of life. Supportive interventions. Supportive interventions are strategies and resources selected after assessment of the individual level of ability and can help improve the functioning of the individual with an ID. The rationale for supportive interventions include: promote development, education, interest, and personal well-being, improve individual functioning and functional capabilities, lessen the person's disorder by providing services and interventions that focus on prevention, enhance personal outcomes related to independence, community participation, and personal well-being. Dental hygiene care is one of the supportive interventions needed to support the patient's freedom from oral discomfort and pain, maintain oral health. Learning self-care for daily and oral biofilm removal, improve quality of life. The classifications of intellectual developmental disabilities. The traditional levels of intellectual functioning have been included: mild, moderate, severe, and profound. However, the International Classification of Disease 11 added the following classifications: provisional and unspecified. Standardized intelligence tests are used to assess the overall intelligence quotient, IQ, as well as verbal comprehension, visual spatial skills, fluid reasoning, working memory, and processing speed. Onset of the ID is before age 18. A diagnostic category of unspecified is when the standardized tests cannot be performed because of lack of cooperation, severe impairment, or infancy. Mild. The IQ approximate range 50 to 69 in adults mental age from 9 to under 12 years. Impairment of adaptive behavior. Slower in acquisition and comprehension of complex language, academic, social, and daily living skills. Practical life skills such as basic personal self-care and domestic activities can be learned, and these individuals can function with minimal support. They often can live semi-independently in group homes and maintain employment as adults with minimal support. Moderate. IQ approximate range 35 to 49. Adult mental age from 6 to under 9 years. Impairment of adaptive behavior. A marked developmental delay occurs in the early years. Child can be trained in personal care and hygiene with moderate support. Capacity for language and academic skills is limited to basic skills, and they may not learn to read or write. Not completely capable of self-care and may require considerate, consistent support in order to be semi-independent and maintain employment as an adult. Severe. IQ approximate range 20 to 34. Adult mental age from 3 to under 6 years. Impairment of adaptive behavior. Very limited language and communication skills. Limited capacity for academic skills. Motor impairments require daily support in supervised settings. However, the extensive training they may be able to acquire basic self-care skills. Profound, IQ under 20. Adult mental age is below 3 years. Impairment of adaptive behavior. Severe limitation in self-care, continence, communication, and mobility. Close supervision and assistance with self-care and activities of daily living are necessary. These individuals are not able to live independently. Provisional. This diagnosis is assigned when there is evidence of an ID, but the individual is an infant or child under the age of 4, so it is not possible to conduct an assessment of intellectual functioning or adaptive behavior because of sensory or physical impairments, severe behavioral or mental disorders. The etiology. Anything that interferes with normal brain development can result in ID. Genetics. Down syndrome is the most common cause of ID, 1 in every 700 live births. Fragile X syndrome, FXS, is the most common inherited cause of ID and occurs in 1 in 5,000 males. Non-genetic, exposure to toxic substances, prenatal alcohol exposure, prenatal postnatal lead exposure, nutritional deficiency, iodine deficiency, brain radiation, childhood brain infections, traumatic brain injuries, maternal infections, rubella, cytomegalovirus, complications of prematurity, hypoxia, or periventricular hemorrhage. The etiology of some IDs is unknown. The treatment. Early diagnosis is essential to identify any comorbid medical, behavioral, or mental health disorder and determine services necessary to maximize their potential and quality of life. Treatment falls into 3 categories. Address or manage any underlying causes of ID, such as the need to restrict phenylalanine in someone with phenylketonuria. Management of comorbid physical or mental health disorders to improve functional and life skills. Early behavioral and cognitive interventions, special education, and psychosocial support to optimize functioning. General characteristics, physical features. Many individuals with ID may not have unusual physical characteristics. Delays in physical and motor functioning, such as walking, running, jumping, is often associated with a lower IQ in this population. Physical characteristics are most prominent in Down syndrome and FXS and may include facial or other characteristics, may be pathognomonic for a particular condition or syndrome. For example, Down syndrome is described later. School anomalies include microcephalus, smaller, hydrocephalus, larger, contains fluid, spherical, conical, or other asymmetrical shapes. Dysmorphic features such as asymmetries of the face, malformations of the outer ear, anomalies of the eye, or unusual shape of the nose may become apparent as the child develops. Oral findings. Higher levels of dental biofilm are present. The gingival health of those with ID is worse than without ID, but it remains unclear if the periodontal status is worse based on a systematic review and meta-analysis. Dental caries. Research on caries rates of those with ID do not agree, and at the same time, evidence suggests the risk for caries is similar to the general population. However, the rate of untreated caries is higher, with more missing permanent teeth due to caries. Level of functioning, medication-induced xerostomia, and the ability to perform oral self-care, along with feeding issues, chewing and swallowing disorders, use of sugary foods as rewards, gastroesophageal reflux, are risk factors for dental caries. Oral developmental malformations such as malocclusion, protruding tongue with macroglossia, narrow short palate, microstomia, and delayed tooth development. Oral habits, clenching, bruxing, mouth breathing, tongue thrusting. Oral hypersensitivities, hyperactive bite, and or gag reflex. Factors significant for dental hygiene care. Patients with ID often experience significant barriers to assessing dental care. Individual factors include cognitive impairment may impact understanding of oral self-care procedures. Oral motor conditions may make oral self difficulties. The individual may bite down on the toothbrush or make it difficult for a caregiver to assist with oral care. Oral tactile sensitivity, such as gagging, may make oral care difficult for those who support the individual. Challenging behaviors making it difficult to perform oral care at home and in a dental setting. Social factors include caregiver education and support for regular home and professional oral care. Environmental factors include transportation for professional care. Living in a residential setting may present a barrier to regular dental visits unless dental care is provided on site. Down syndrome. Unique group of individuals with ID caused by a chromosomal abnormality, also referred to as trisomy 21 syndrome. Live birth prevalence is about 12.6 in 10,000 in the United States. Life expectancy has increased dramatically from the 30s in the 1980s to 55 years due to advancement in medical treatment and social support. Most live with family in private homes or settings such as group residential homes and assess healthcare, as well as dental care services within their communities. Physical characteristics. Poor muscle tone and altered gait, decreased walking speed, reduced step length, wider base of support to compensate for differences in muscle tone, short neck, flattened facial profile with a flat nasal bridge, slanted eyes with the epicanthic fold of skin continuing from upper eyelid over the inner angle of the eye. Small mouth and large tongue, hyperglossia, small hands with short fingers, and the palm has a single transverse palmar crease. Gastrointestinal problems may include intestinal obstructions. Cognitive and behavioral characteristics. Typical characteristics listed here may impact management approaches for dental and dental hygiene appointments. Many individuals with DS have mild to moderate ID. Common cognitive functioning characteristics include short attention span, impulsive behavior, slow learning, delayed developmental milestones such as speech, development, and language. Reduced working memory capacity, temporary memory, and long-term memory for explicit factual memory. Poor ability to process information delivered verbally, slower to gain new skills with more difficulty, with stability of these new skills meaning they may not be able to repeat a skill at a later time. Nonverbal reasoning, ability to understand, interpret, and analyze visual information, and solve problems using visual reasoning. The DS individual may have difficulty with complex sentences. Comorbidity and health considerations. Although improvements in health care and immunizations have resulted in a longer life expectancy, many patients with DS also present with additional special needs and comorbid health concerns. Common medical problems include cardiac problems. 50% of DS babies have congenital heart disease. Ventricular septum defects affect about 35%. Neurological conditions. Seizures. Those with DS are at a greater increased risk of early onset Alzheimer's disease. Hematologic problems. DS individuals have a 10 to 20-fold increase for leukemia. Gastrointestinal problems. 12% experience intestinal obstruction. GER is also common because of reduced muscle tone. Dysphagia is also common and may result in aspiration pneumonia. Visual problems. Nearsightedness, eye crossing inward, and congenital cataracts are common. White spot, brush field spots on the colored part of the eye. Abnormalities of the immune system resulting in an increased risk of infection and severity of disease, particularly respiratory tract infections. Ear infections due to congenital ear abnormalities, which may result in hearing loss. Obstructive sleep apnea and airway obstruction is extremely common in DS due to airway abnormalities. Anatomic anomalies, oral findings. Macroglossia with protruding tongue, macrosomia, narrow vaulted palate. Dental anomalies. Delayed or irregular sequence of eruption, congenitally missing teeth, irregularities in tooth formation, hypoplastic enamel, microdontia fused teeth. Class 3 malocclusion and posterior crossbite are common and relate to the flat face and underdevelopment of the midfacial region. Prognathic appearance. Teeth may be spaced because certain anomalies teeth take less space. Mouth breathing is common. Periodontal infections are more prevalent and often more severe in people with Down syndrome. Poor oral hygiene, bruxism, xerostomia. Children and young adults with DS have a lower prevalence of dental caries. Factors that may contribute include delayed eruption, congenitally missing teeth, and microdontia, small teeth, may result in a wider interdental spaces, reducing food accumulation. Factors significant for dental hygiene care. Individual factors may include review the medical and medication history with the caregiver and carefully investigate any medical condition in order to plan safe dental and dental hygiene treatment. Consultation with a medical provider may be necessary. Careful attention by the dental hygienist to effectively communicate by using simple, clear language along with visual aids to help educate the patient. In addition, repetition will be necessary due to memory issues. Cognitive limitations along with impaired vision or hearing may impact understanding of oral self-care instructions. Typically, behavior is not an issue, but talk to the caregiver to determine the most effective way to manage any negative behavior. Minimize stimuli, that is noise. Positioning of the chair may need to be adjusted if the patient has respiratory problems. More frequent periodontal maintenance may be necessary. Social factors include children with DS may have access to occupational therapy or OT. OT assists people with self-care tasks and may be a resource to assist with oral hygiene skills. Caregiver education and support for routine oral care will be important to prevent and manage oral disease. Environmental factors include determined living arrangements, as those living in a residential center may have more difficulty finding transportation for routine dental care. Fragile X syndrome. FXS is the most common genetic cause of inherited ID, the most common single gene cause of ASD. Boys are mostly severely affected because this condition is associated with the X chromosome. Girls are often carriers, carry the gene on one X chromosome, but will not exhibit the characteristics unless both X chromosomes are affected. Physical characteristics: prominent forehead, narrow long face, protruding ears, connective tissue dysplasia resulting in hyperflexibility of joints. Cognitive and behavioral characteristics: common cognitive and behavioral characteristics: IDs, hyperactivity disorder, ASD, weakness in short-term and working memory limit the ability to retain and process new information. Limitations in executive function with controls aspects of behavior such as attention. Difficulty with visual motor coordination, which means they may have trouble with motor skills like toothbrushing. Relative strengths include verbal reasoning, ability to understand and logical work through problems, and simultaneously processing, ability to see the big picture and understand relationships. Comorbidity and health considerations: recurrent otitis media because of collapsible eustachian tubes. Neurologic conditions include seizures. Movement disorders such as hand flapping is common in FXS. Gastrointestinal issues, GER, diarrhea, ocular disorders are common, and many individuals with FXS require glasses for correction. Sleep problems occur in 10 to 25% of children and teens. Obstructive sleep apnea occurs in about 1/3 of individuals. Airway obstruction is also common. Oral findings: high arched palate, mandibular prognathism, macroglossia, enamel hypoplasia, malocclusion, dental caries, gingivitis, poor oral hygiene, medication-induced xerostomia with saliva with a low buffering capacity. Factors significant for dental hygiene care include: the dental hygienist needs to carefully investigate the medical history and medications along with questioning the caregiver on behavioral considerations. Explore cognitive and behavioral limitations as well as any vision or hearing issues prior to the first visit. Behavior may result in lack of cooperation with caregivers for oral care. Understand issues with short-term and working memory and adjust oral hygiene education accordingly. Visual motor coordination may make it more difficult for the patient to learn oral self-care techniques. If GER is present, along with medication-induced xerostomia, additional strategies may be needed to prevent caries such as prescription fluoride. Social factors include caregiver education and support for routine oral care will be an important part for preventing and managing oral diseases in the FXS patient. Autism spectrum disorder. Autism, first described by Dr. Leo Kanner in 1944, is a complex spectrum of developmental disorders marked by limitations in ability to understand and communicate. Usually appears during early childhood and persists through life, although many individuals with ASD can learn coping behaviors to enhance daily functioning. It manifests as a range of disorders. Comorbidity with other disabling and medical conditions are common. The prevalence. Prevalence has increased in the past 2 decades. The prevalence of ASD, according to the National Health Center for Health Statistics in 2016, was estimated to be 1 in 36 children. Some increase in prevalence may be attributable to better diagnostic criteria and more frequent screenings. It occurs in all racial, ethnic, and social groups worldwide. Frequency of occurrence is almost 5 times greater in males than in females. Etiology. The etiology is multifactorial, with genetic and environmental factors playing a role. Genetic factors are estimated to be between 30 and 35% of risk for autism. There are about 40 prenatal, perinatal, and postnatal risk factors that may increase the risk for autism, but more research needs to be done to understand how the risk factors work in combination in the development of autism. Prenatal risk factors include advanced maternal or paternal age greater than equal to 35 years, mother or father's race, white or Asian, maternal and paternal education level beyond college graduate, gestational diabetes, gestational hypertension, antepartum hemorrhage, vaginal bleeding between the 20th and 24th week of pregnancy and birth of the baby, threatened miscarriage, bleeding, and abnormal cramping. Perinatal risk factors include cesarean delivery, gestational age less than or equal to 36 weeks, breech birth, preeclampsia, fetal distress, induced labor. Postnatal risk include low birth weight, postpartum hemorrhage, male gender, brain anomaly. Characteristics. The onset of autism is typically before age 3, and some parents may notice signs in the first year of life. Signs may include delays or abnormal response in the following: social interactions, language, symbolic, or imaginative play. Persistent deficits in social communication and interactions across multiple contexts, such as the following: impairment in nonverbal communication for social interactions, eye-to-eye gaze, facial expression, gestures; deficit in developing, maintaining, and understanding peer relationships appropriate for the developmental level; lack of social or emotional reciprocity or inability to initiate and respond to social interaction; restricted interest and repetitive behavior manifested by at least 2 of the following: highly restricted patterns of interest that are abnormal in intensity or focus; insistence on sameness and inflexibility adherence to routines or rituals; extreme stress with small change; repetitive body movements, use of objects or speech; hyper or hyporeactivity to sensory input; adverse response to specific sounds or textures. Severity designation is based on the level of communication impairments and behavior patterns. Comorbidity, ASD, is commonly associated with other intellectual impairments, structural language disorders, attention deficit and hyperactivity disorders, learning disabilities, and seizure disorders. Treatment interventions. There is no cure in the medical sense for autism. Interventions usually target behavioral issues and support behavioral adaptations. Early intervention services. Early intervention targets children from birth to 3 years old to provide service to improve development in the following areas: physical, such as walking and crawling; cognitive, such as learning, problem solving; communication, such as speech; social emotional, such as play; self-help, such as eating and dressing. Pharmacologic treatment is complex due to the heterogeneity or variation in behavior and severity of behaviors in an individual with ASD. The purpose: relief of negative behavior symptoms such as severely disruptive behaviors and hyperactivity. The 2 medications with Food and Drug Administration approval for treatment of severely disruptive behaviors, also referred to as irritability, are risperidone and aripiprazole. Treatment of repetitive and compulsive behaviors with serotonin reuptake inhibitors such as fluoxetine has also shown promise in adults with ASD, but research in children has been inconsistent. Medication for the management of hyperactivity has been mixed, with some studies reporting psychostimulants like Ritalin, methylphenidate, but other studies show an increase in irritability. Identification and medical management of comorbid, potentially treatable conditions: epilepsy, seizures, allergies, gastrointestinal problems, or sleep disorders can lead to quality of life improvements. Cognitive behavioral therapy, a form of treatment that focuses on relationships between thoughts, feelings, and behaviors. The purpose is to help people with autism lead more normal lives by decreasing anxiety and increasing their ability to respond to everyday stimuli and appropriate coping mechanisms. No one behavior-based or educational approach is effective in alleviating symptoms in all cases of autism because the spectrum nature of the condition and the many behavior combinations that can occur. Examples: special teachers in intensive structured programs directed toward individual instructions, applied behavior analysis, sensory integration, music therapy, OT, speech and language therapy, and auditory integration training. Applied behavioral analysis has been widely used and encourages positive behavior while discouraging negative behavior. Controversial treatment. Dietary approaches for treatment of ASD are not evidence-based. However, those with ASD often have a restricted diet, which may impact overall health. In particular, evidence is emerging for lower protein, calcium, and phosphorus intake, resulting in lower bone mass. Caregivers should be discouraged from restricting diet choices without oversight by medical providers. Complementary and alternative treatment currently have no conclusive evidence to support efficacy. However, music therapy as a component of behavioral therapy may impact several aspects of ASD, including communication, emotion, and social reciprocity or response to social interaction. Factors significant for dental hygiene care. Poor oral hygiene and gingivitis are common. Impairment in social interactions and difficulty in shifting focus of attention make traditional oral health education approaches difficult. Repetitive body movements and mannerisms may compromise patient safety and impact infection control protocols. The dental hygienist needs to carefully investigate the medical history and medication along with questioning the caregiver on behavioral considerations. Patients and a consistent approach and patient preparation prior to the appointment can enhance the probability of a successful dental visit. Approaches to dental care for patients with autism. Determined Program, DTP, of familiarization and repetitive tasking. DTP is a behavior guidance approach based on ABA for dental professional development for use specifically for patients with ASD. Pre-treatment assessment form together information about behavior challenge and what motivates a child. Familiarization visits, practicing and learning cooperation skills. The benefits include improved and behavior, fewer referrals for dental treatment under general anesthesia, resulting in lower costs for dental care. Cooperation skills to be learned include positioning oneself in the dental chair, sitting with legs straight and hands at side on the tummy, making eye contact as instructions are given, opening the mouth and remaining consistently open, allowing instrumentation and responding appropriately to instructions. The 5 D steps for learning cooperation skills. Divide the skill into smaller parts. Demonstrate the skill. Drill the skill. Delight the learner. Delegate the repetition. Autism Speaks Dental Toolkit. The toolkit is designed to provide tips to dental professionals for patient care, teach families how to prepare the visit to the dentist, decrease anxiety about the dental visit, provide information for good oral health for a lifetime. Additional strategies for dental care. In addition to the previously mentioned program, there are a variety of strategies for preparing to have a positive experience in the dental visit. Desensitization with familiarization visits may also be planned. Visual pedagogy is a way to educate the child with ASD through pictures. Create a personalized picture book of the steps in the dental visit to be reviewed at home in preparation. Social stories are widely used strategy for ASD. And focus on the short story to provide an understanding of the social information for a setting and the behavioral expectations. Video modeling to teach behavior related to the dental visit, as well as oral home care. The dental hygiene care. Appointments for medical or dental health care may be overwhelming because of all the unfamiliar stimuli for many patients with neurodevelopmental disorders, especially for patients with ASD. Dental care may have been neglected due to problems with social interactions, language and communication problems, or difficult behaviors. Severity of symptoms dictates the appropriate settings for delivery of dental services for these patients, with some modifications to the treatment plan and implementation of appropriate behavior guidance techniques. Patients with mild to moderate manifestations of the condition may be treated successfully in the general dental setting. Patients with more severe symptoms may require sedation, general anesthesia, or immobilization in a hospital or specialized settings. Oral health problems. Previous dental care. Dental care may have been a low priority due to challenges the caregiver encounters in completing the activities of daily living. Reasons for unmet dental needs. The child's behavior and parents' embarrassment about the behavior are major barriers to dental care. Cost of treatment. Particularly if general anesthesia was recommended. Parents may be resistant to use the protective stabilization in children unable to follow direction or with behaviors that may cause them harm in the dental chair. Unpleasant experiences from the dental visit. Dental caries. Feeding problems can lead to offering foods that will be accepted without regard for nutrient contents or caries prevention. Dietary selection may have limited needs for sameness, with the possibility of serving in excess of cariogenic foods. Sweet food rewards for behavior modification guidance repeated frequently over time promote dental carie development. Aversion to certain food textures can lead to extreme diets that result in either entirely soft food selections or entirely hard, crunchy, crispy food selections with low nutritional value. Foods used in therapy sessions to stimulate food or to stimulate speech or help develop the muscles necessary for improved language are frequently cariogenic, chewy, or sticky candy. Oral hygiene. Daily oral care procedures may be inadequate for the uncooperative individual, even when delivered by an informed caregiver. Strategies suggested in the resources of the child with autism, such as those provided by Autism Speaks, can be useful for most children with neurodevelopmental disorders. OT may be able to assist with sensory issues some individuals experience to familiarize them with the sensations associated with routine oral home care. Dental staff preparation. Be familiar with the various neurodevelopmental disorders and prepare for visits by doing the following. Review the medical and dental and personal histories with the caregiver by telephone interview in advance of the first office appointment. Both the DTP and Autism Speaks resources previously discussed have a form that can be used to gather specific information about behavior and sensitivities. Discuss information with the parent and caregiver, primary care provider, or other health care provider associated with the patient. Gather specific information about appropriate motivators and rewards that are safe and effective reinforcers for the individual. Consider some of the strategies previously mentioned for those with ASD for pre-appointment familiarization the parents' caregivers can do at home, such as place a plastic mirror and flashlight in and out of the mouth. Follow commands such as hands on your tummy, feet out straight. Plan several short orientation and familiarization appointments, initially with not more than a week between visits. Involve the same member of the dental team at each appointment to avoid distressing the patient and losing time for reorientation. Dental hygiene care. Plan for four-handed dental hygiene treatment for the resistant patient. Frequent appointments to prevent oral disease are recommended. As the patient becomes more cooperative, increase the preventive services they will tolerate, which may include dental biofilm control for the patient and the caregiver, debridement as needed, fluoride varnish therapy, and dental sealants. Appointment considerations. Create a quiet environment from stimuli. Patients with autism may have sensitivity to light, sounds, touch, and smell. Avoid loud, inconsistent background music, noisy dental equipment, and irrelevant conversations. Avoid unnecessary touching during treatment. Provide sunglasses for the patient with light sensitivity. Placing the lid apron on the patient to induce deep pressure touch stimulation may help the patient feel more secure and stay calm. Desensitization practice. Begin with orientation to the setting in each part of the equipment. If the patient is not ready, instrumentation may not be included at the first appointment. Instructions take place. The form tell, show, do to repeated many times. Patience and firmness are necessary elements. Have the caregiver help condition the patient by giving a plastic mouth mirror and a few dental films to take home for practice in the mouth daily. Use the behavior guides procedure when the patient condition is appropriate. Involve caregiver while presenting preventive measures. Ask the caregiver or parent if the ABA therapist could attend the first dental visit. Provide reinforcing rewards. Use inedible rewards, stickers, picture cards, child-safe tokens, or toys, and explain the rationale against cariogenic foods. Protective stabilization. Protective stabilization is considered an advanced behavior guidance technique in dental settings, and the clinician must have adequate training and appropriate, safe, and effective use for a patient who is unable to cooperate. Other less restrictive approaches to behavior management should be attempted prior to using protective stabilization. Written informed parent-guardian consent is required from the parent and guardian pre-procedure. The risks and benefits must be explained prior to asking for informed consent. Parental presence in the operatory may be helpful for both the parent and the child. Documentation. Chronologic age versus developmental age. Communication strengths and weaknesses with the parent and caregiver. Helpful behavioral supports and guidance techniques. Treatment that was accomplished and modifications to treatment that were helpful. Recommended home oral hygiene and behavior practice skills.